Hello, it's Dr. Rafael Gutierrez, and today I'm going to talk about cardiovascular embryology and its basic anatomy. And one of the things that I will tell you and warn you, especially if you go on more advanced classes, is that the vascular system actually can change a lot within one human to another. Sometimes you'll have branches that are present in one individual. Sometimes you'll have anastomosis that only affect certain individuals. And so a lot of times when we are teaching things like the vascular anatomy, we teach probably about what 90% of people would have. That doesn't mean that 90% of people would look exactly like this, but rather if we take 100 people with the variabilities, 90% of them would have these specific structures in this specific way. And you do have a lot of variations. So a lot of times it's actually better to understand where the arteries are running rather than are they always coming from a certain area. And so just a little FYI if you're going to be taking really advanced anatomy classes. But for the most part, this is what you would see in a typical human. Now, the embryology actually starts with what is called two heart tubes. So you'd have the head up here, the tail or butt end down here, and you'd have two heart tubes, and they'd be pretty much beating going around. Now, what ends up happening is eventually the heart tubes fuse, and so you have one heart tube. And the blood is coming from down through the heart tube and then up. And what you're eventually going to get to is the head. And in embryology, what we see is these two vessels are actually initially going to go to the pharyngeal gill slits, where if you were a aquatic vertebrae, you would end up getting your oxygenation there. As we continue to go, we end up forming a lot of different bulges in it. The top one here is a bulbous cordus, and it's going to seem like I made a mistake, but it's not. It actually is. The primitive ventricle is under that. Then under that you have the primitive atria and the sinus venosus underneath it. So veins are bringing blood back to the heart, arteries are going away from the heart. And that's one of the things you'll actually see over and over again. So if you can't remember A is for away. So if blood is moving away from the heart, it's a artery. Now, as this continues, the bulbous cordus comes down, the ventricle starts moving up, and it pulls the atria with it. And so you can actually see how it actually continues to move up. And eventually what you have is you have this bulbus, the ventricle, and the atria up on top. And what you now have is you now have a S-shaped type heart. Blood will be coming in from this side here, atria to the ventricles, and then out. And this will eventually we'll see a split in the atria, giving us a three-chambered heart. So we have the atrium on top, ventricles on the bottom. Remember, whenever we're dealing with anatomy, we're always dealing with anatomical position. So what I'm talking about is you have the venous sinus here. The venous sinus drains into the atrium into the ventricles, and then it goes out the body, and it continues to cycle over and over again, now with a three-chambered heart. The atria are on top, ventricle are on the bottom. Now, what ends up happening is, and I'm trying to use the same pictures, is you actually have the development of certain portions of the electrical system of the heart called the neural crest cells, and they form something called the endocardial cushion. And the cells start moving up, forming what's called the septum premium, or primary septum. Septum premium or primary septum pretty much just means the first septum. And so what ends up happening is we actually make a division in our atrium. And so we have a right atrium and a left atrium. So if we're actually looking here, we'd see the right atrium and the left atrium. Remember, this is always an anatomical position, so it's what you see. And both of them are pumping into the ventricles. And so what we have is we have a three-chambered heart in development. And there are some animals that do have a three-chambered heart. Now the septum premium develops a septum secundum, and it closes it off completely. Then part of the septum secundum dies, allowing a hole here. And that hole, we call it the foramen ovale. Now it does have the flap, and what it allows is it allows mixing of blood between the right atrium and left atrium, which we'll talk about later, and it's going to go into the ventricles. Now, the other thing that happens is the blood supply changes. So the blood that's coming from the venous system into the right atrium is coming from the body, so it tends to be deoxygenated. And what we usually do is we show it as blue. The blood that's coming into the right atrium from the venous system here is coming from the lungs, so it's oxygenated. So these would actually be pulmonary veins going into the left atrium. Now both of these at this moment are going to be pushed into the ventricle. Right at this point you still have 3 chambers, 1 ventricle, and you have a tube coming out of the right side and another tube coming out of the left, and those 2 tubes are the great vessels. And what has to happen, one of them is called the pulmonary trunk and one of them is called the aortic. Initially the pulmonary is on the left side, pulmonary is on the left side, the aortic is on the right, and they have to switch. If they don't switch, the next part of the heart doesn't quite work. Because what you have to do is you have to make the ventricle into 2 ventricles by making a interventricular septum, which I'll talk about in a little bit. So when you don't have the 2 ventricles, blood can move from the right side to the left and from both the right atrium and left atrium into the ventricle. And so you have a mixing of blood which is going to be pumped out. At this point, the big artery that will become the pulmonary trunk and the aorta are not split, and so we call it the truncus arteriosum. It hasn't split. It will, and it will move. Now we do have a condition called transposition of the great vessels, which what happens is the vessels actually fail to move. So what has to happen is prior to forming the 4-chambered heart, the area where the right ventricle and where the aorta and the pulmonary trunk have to switch sides. If not, they're on the wrong sides and it's not compatible with life. So here we now actually can see a 4-chambered heart. If we actually start with the blood coming back from the body, we see a big vessel here, another big vessel coming in here, and this depression here is called the fossa ovale, which would be where these 2 were actually connected at one point. When you take your first breath of life, the foramen ovale closes, and so you have the fossa ovale. So blood comes into the right atrium. From the right atrium, it pumps and it goes through a valve here, which has 2 cusps, so it's a bicuspid valve. And this is now, because you've actually formed a chamber here, a septum here, this is now the right ventricle. The right ventricle will pump through the pulmonary valve to the pulmonary trunks to the lungs. The lungs, you pick up oxygen and you go into the pulmonary veins into the left atrium. Remember, if you're actually looking at a model, the pulmonary veins will be red because they are oxygenated, but they're still veins because they're coming into the heart. From the from the left atrium, you'll pump through the bicuspid valve here. I'm sorry, it's tricuspid here, bicuspid here, into the left ventricle. From the left ventricle, it'll pump out the aorta, and that will go to the rest of the body and come back to the right side of the heart. Remember, arteries carry blood away from the heart, so A is for away, veins bring it back to the heart. Now, like I said, you do have the foramen ovale, and at birth it closes because it changes in pressure. So you now have that hole closed, but you leave a little indentation, which we call the fossa ovale. There's actually a connection between the 2 arteries, the pulmonary arteries and the aorta, and that's called the ductus arteriosum, and that closes, giving you the ligamentum arteriosum. And if these don't happen, it actually causes a reverse of blood. But in fetal heart, before you're born, the reason you have these 2 shunts is because you don't get air from your lungs. So you end up actually having to use the shunts to bypass. Okay, now I mentioned the valves. You have the tricuspid and the bicuspid, and what ends up tricuspid here, bicuspid here, right? And what happens is these valves are actually made of dense connective tissue, and they're covered with endothelium. It's pretty much a thin layer of flat cells. And what these do is they help prevent backflow. They help keep the blood moving in multiple directions. If for some reason these valves are leaky, you'll have a backflow, and so it will change the way the heart beats. It will cause pressures to increase or decrease in certain areas. You do have tendons holding the valves together, which we call them chordae tendineae. Chordae for cardiac, heart, tendineae for the tendons. And you'll see these finger-like projections, which are called papillary muscles. And a papilla are these pretty much just finger-like projections. You'll see that word over and over again. And so when we circulate the heart, blood in the heart, blood comes from the body to the right atrium through the tricuspid valve to the to the right ventricle, from the right ventricle through the pulmonary trunk to the lungs, to the pulmonary arteries, to the left atrium, bicuspid valve, left ventricle, aorta, and then it goes through the rest of the body. Now, there are a lot of vessels that are coming off and part of the blood, and so it's important to actually look at that. Now, you can see these two big veins here are coming into the right atrium. You can also see this ear-like projection, which is called the auricle here. And if we're dealing with circulation coming into the body, the first thing you actually want to look at is these vena cavas, these big veins. This one here is above, so we call it the superior vena cava. The one below would be the inferior, and you have other vessels coming into the inferior vena cava. It's the inferior vena cava all the way down. If we look at the heart, again, we see the pulmonary trunk, and this image did cut the pulmonary arteries, which go to the lungs, and the pulmonary veins would go to the right atrium, like I said. And then you end up going through the aorta. Now, the aorta has three parts. It has a ascending aorta, the aortic arch, and the descending aorta. And it's aorta all the way down until it splits at the very end. You'll also see two vessels coming off here. These two are the right and left coronary arteries. Now, you'll notice that the coronary artery branches and it goes down the front of the heart. As you have a depression in the heart, we call it a septum. And so the artery here has a couple different ones. It can be the left anterior coronary, descending coronary artery, or you can sometimes see it as the anterior interventricular artery. So the sulcus is a depression. The interventricular sulcus, the anterior interventricular sulcus is here. The atrial ventricular sulcus is here. And you can see the blood vessels as they go to feed the heart first. Now, before I actually go into that, I should talk a little bit about the electrical conducting system of the heart. Now, what's neat about the heart, and you'll learn a lot more of this in physiology, is the heart is an auto-depolarizing organ, which means it causes its own depolarization. It causes its own activity. If someone were to remove a heart, it would continue to beat as long as it's alive because of this. And so you have different nodes that we can talk about. One of them is called the sinoatrial node, which will be at the top here next to the superior vena cava. You do also have the atrioventricular node, or the AV node, which, if you notice the name, atrio for atrial, ventricular for ventricular. It's going to be more on the left side, the right side here. And you do have a couple other things, bundle of His, which I'll show you after this. AV node, bundle of His is going to come off, and it branches into the right and left bundle branches. And then you have Purkinje fibers that go deep into the heart. So over here you can see where the sinoatrial node is, what people call the SA node. The AV node would be around this area here, atrioventricular node. The bundle of His would come off here, and the bundle would branch into right and left branches, and then you'd end up having the Purkinje fibers. Now, it's just showing you how the heart is actually located on the side. And I do want to talk about EKG. EKG, or ECG, it stands for electrocardiogram. So it's a tracing of the electrical activity of the heart. It is not the contraction. This is just looking at the electrical activity, and if the electrical activity is moving to one side or another. What happens is it's not looking at is it a positive charge or negative charge. It's just looking, is there a charge and is it moving one way or another? And they initially, in the more basic 3-lead EKG, they actually dealt with the left side as being a positive direction and the right side as being the negative. So if anything is moving from right to left, it will show up as positive. It does not mean the charge is positive. It means that the charge is moving in that direction. The right would show a negative deflection. Again, if the charge is moving, whether the charge is positive or negative, if the charge is moving, it is to the right, it is going to be seen as a negative. You can have electrical activity, by the way, and not have a contraction. If you take CPR, you'll talk about the pulseless electrical activity. But you cannot have contraction without electrical activity. So a lot of times when people are actually studying heart and actually eventually dealing with CPR, they tell people to check a pulse before looking at the EKG. So if someone has a flat line, check their pulse, because if they have a pulse, their heart is working. It's just that something happened with the monitor. It could be a lead, one of the leads fell off. So EKG and ECG are the same thing. It's whether you say it cardio with a K or cardio with a C. Now, how to find certain things in the heart. And what we have is we always look for things we already know. Now over here you see the manubrium, the sternal body, and the sternal angle. This here is a second rib, and between the second and third rib you have the second intercostal space. On the other side we have second intercostal space, so we break them up between the right and left. Now if we actually are up here in the right area, the right intercostal space, we actually can hear the aortic valve here. Now the aortic valve is a bit farther down, but this is where it's hurt, the second intercostal space, right side. And you'll notice that the aortic valve is actually on the left side of the heart. The reason is the way the heart twists within your body. If we go to the right side, that means we'll hear the pulmonary artery. And then we can actually go down to the fifth intercostal space near the nipple, and we can hear the tricuspid and the bicuspid valves. Now, one of the things that I will tell you, you remember how I mentioned at the beginning that a lot of times things can actually change depending on different people. There are some people who their heart is switched around. There's a condition called, one of the many, called situs inversus, where everything is flipped over. But that is not seen too often, so usually in basic anatomy, we just deal with the normal 90% anatomy. It doesn't mean that you should forget that. If you look at it and you find stuff, you should actually, if you're working in clinic, document that. Now, I started talking about the arterial supply of the heart, and you can see it here. Now, I like to use terms like atrioventricular, intraventricular, because it tells you a lot. Atrioventricular, atrium, ventricle, ventricle. So atrioventricular sulcus, intraventricular sulcus between the ventricles. And so you will see these things come across over and over again. Now, when we actually look at the veins, we have a lot of veins in the heart, and I just want you to know a couple of them. One of them is this big thing called the coronary sinus, which drains into the heart. And there's big veins that actually drain in here. Most of them have the same view, but sometimes with veins you have more variation. And one of the things you'll notice is you have a big vein coming here, coming around to the front of the heart, and so we call it the great cardiac vein. Once it gets in here into the intraventricular sulcus, it is the anterior intraventricular vein. Now, on the opposite side, you have a small vein that comes around here. And so as it's a small vein, we call it the small vein. As these veins are coming on the margins here, marginal veins, and then you have one between them, which we call it the middle vein. And so those are actually all going to come to the coronary sinus. Now, the major arteries. I talked a little bit about the arteries of the heart. I mentioned a couple of them. There is a circumflex artery, which you'll see in lab and you'll see in the lectures. But usually the big arteries are the ones you want to look at for this. Now, I talked about how arteries are under more pressure. And so they have thicker tunica muscularis. And when you're dealing with this, I always tell people to know their ABCs. And when I say ABCs, I do mean ABCS. A for aorta, B for brachiocephalic, C for common carotid, S for subclavian. So if we look at this, we have the aorta, the aortic arch is here, and we can see 1, 2, 3 veins coming off of that. I'm sorry, 3 arteries coming off of that. The first artery here is going to branch, and one of them is going to go to the head, one of them is going to go to the arm, so we call this one the brachiocephalic artery. Or sometimes you'll see brachiocephalic trunk. Now over here, you have the common carotid. Technically, this one here is going to be your left common carotid. And as you have 2 carotid arteries, you have one on the left side, and in the brachiocephalic, it branches. One that goes to the head is the right common carotid. So you have 2 common carotids. So you have A, B, C, and S is for subclavian artery. Subclavian means under the clavicle. So this artery will run pretty much deep to the clavicle. Now, this would again be your left. So on your right, coming off the brachiocephalic, you have the subclavian artery here. So there's 2 ABCs, the aortic arch, brachiocephalic here, the left common carotid, the left subclavian, or aortic arch, brachiocephalic, right common carotid, and right subclavian. We'll have more. Now, once it starts going down, it's called the descending aorta, and in this region, as it's in the thorax, we call it the thoracic aorta. You can see the heart here, and within the ribs, you can see a artery go pretty much across here, branching straight off the thoracic aorta. Those are called your intercostal arteries. If you remember in skeletal, costal will mean ribs. And then they pass under the diaphragm. But before they do, you do have 2 superior phrenic arteries. The phrenic arteries feed the diaphragm. Going through the abdomen, you can see it coming here. The aorta is called the abdominal aorta, and you can see how it branches here. Over here, it's called the common iliac artery, and you know the bone here is the iliac bone, and so it's named after the bone it's there. And that's going to be very important as we go on. Now, it looks like a mess. You can see actually an artery coming up here feeding the diaphragm, so the inferior phrenic artery. And you have a big thing here which branches into 3 things. One of these will go to the liver, which will be called the hepatic artery. Anytime you hear hepato, it means liver. One of them will go to the spleen, which will be the splenic artery. And you'll have a couple going to the stomach called the right and left gastric arteries. And they will have tributaries coming off, which will feed other arteries, other organs, and they'll be named for those organs. As we come down, we can see branches that come to the kidneys, so we call them renal arteries. And the renal arteries do have branches sometimes that go to the adrenal gland above it. And up here, you have an artery that comes all the way down to the gonads, whether they're ovaries or testes. You can only see it here and here. It's cut. They are the gonadal arteries. If you have testes, we're talking about testicular arteries. If you have ovaries, they're ovarian arteries. You also do have up here a big artery that feeds most of the intestines. It's actually the top part, and so we call it the superior mesenteric artery. Now, if you take micro, you will come across something called enteric bacteria. Enteric bacteria are bacteria that are found in the intestines. So anytime you see enteric, it usually refers to the intestines. Mes means middle, so mesenteric means middle intestines. So pretty much the GI tract. And at the bottom, you can see it here, branching off, you'd have the inferior mesenteric artery. And so what you'll notice is the arteries are named a lot of times for the organs that they're going to. Now, I do want to pay a little more attention to the 3 arteries that branch from a common trunk to go to different organs. The trunk is called the celiac trunk. And the reason this is important is because these will go to specific organs. You can see the left gastric, the right gastric, and they make a circle. Here, you can see the splenic and how it has branches off. You can see how these are going to actually go to certain areas. So gastric will be stomach, splenic will be spleen, and hepatic will be liver. And celiac trunk is going to all three of these. Now, I did talk about the common carotid artery. And anytime you hear common, it's going to branch. And the reason I'm coming up here first is because you end up having a lot of different things that, a lot of surgeries, a lot of different clinical sites here. And these are going to go in. Now, anytime you hear common, know that it's going to split. Now, the common carotid artery splits into the external and the internal carotid artery. The internal is going to go straight into the brain, that's it. The external is going to have some branches, and one of the branches will actually go into the skull and form the, they're called the meningeal arteries. They feed the meninges. But here you can actually see a better view of the triangle, what's called the carotid triangle. So you have this here would actually be the muscle of the sternocleidomastoid. Over here, you have what's called the omohyoid muscle, which in muscles we talked about how omo refers to the shoulder and hyoid is a hyoid bone. And over here you have the digastric muscle. And so you have a little triangle here, and in there you can see where the common carotid artery branches into the external carotid and the internal carotid. Now, you do have another thing that's going to actually go to the brain. Coming off the subclavian artery, you have an artery that goes into the vertebrae called the vertebral artery. So this is the vertebral artery, and it will go into the skull as well, and it's going to end up feeding a lot of different structures of the brain. I won't talk too much about the other ones, but as the subclavian artery goes under, it actually does become the axillary artery. And so we'll just deal with the subclavian artery going into the axilla, which is the armpit. And I talked about how you have a bunch of anatomical landmarks. Over here you can see the latissimus dorsi. The pectoralis major would actually be over here. And so if you put your hand in the armpit where the latissimus dorsi, pectoralis major, and in this case coracobrachialis come together, you can actually feel an artery here, which is the axillary artery. And the axillary artery does have a lot of branches coming down, but I want you to pay special attention to the axillary artery. Axilla means armpit. And it does have branches, and once it passes the axilla, it goes into the arm, the humeral region. If you remember, when we were dealing with muscles, the humeral region of the arm was a lot of times referred to as a brachial. So the axillary artery branches a bunch of times and goes into becomes the humeral artery in the humerus area. And you can actually feel it on the medial aspect of the brachial region, the medial antebrachial fossa, if you would, between where we see the biceps brachii, the brachialis is a little bit farther, and the triceps brachii here. And so you can actually feel this. And as you go past it, it's going to branch and give you three different arteries. One of them is called the radial, which will follow the radius. Another one will be the ulna, which will follow the ulna. And interosseous is the one that goes between the two bones. So over here you see how the brachial artery branches. You can see the thumb is over here. So on the anterior portion of the forearm, following the radius would be the radial artery. On the ulnar side, following the ulna would be the ulnar artery, and it is pretty superficial. And you can feel this artery at the wrist. You can also feel it here. And so you can actually have two places where you can have access to arteries, the radial artery and the ulnar artery. And between the bones, you have the interosseous. Now, as you go to the hand, you have this connection. And so we end up making these two arches called the palmar arches. One's called the deep palmar arch, one's called the superficial. And they're going to branch and give radiations to the fingers. And so you actually end up having digital arteries coming over here. Now, one of the neat things is most of the digital arteries run on the sides of the fingers, except for the thumb. And the thumb, it actually runs right underneath here. And that's why when you're learning to take a pulse, that's why you should never use your own thumb to take a pulse. And I've heard people tell me, no, it helps them because they're able to feel other things. Well, if you're using it to feel other things, that's fine. But if you're using it for your pulse, you're going to end up feeling your pulse and the other person's. And so that's why most clinicians, I mean, pretty much all Western clinicians, will avoid using the thumb to take a pulse. Now, we actually did all the arms. There's more arteries, small tributaries we can talk about there. But I just want to show you how the arteries of the legs are actually named. So we have the abdominal aorta, which branches into the two common iliacs. Iliacs, again, named for the bone here, the iliac region. So the common iliacs are going to split. One of them is going to go deep into the pelvic area, pubic area. One of them is going to come out here. And so the pelvic ones here, the big branch is going to be your internal iliac artery. The one that's going to come out here is going to be your external iliac artery. So big thing you can notice is a lot of times when you have a common artery, it's going to branch. If one goes inside, we call it internal. The one that is going to leave that area is going to be the external. So we have the external iliac artery. I'm almost done, I swear. External iliac artery goes under the inguinal ligament through the inguinal canal, and it is found in a triangle called the femoral triangle. You could see the adductor longus, so the sartorius would come across here, and the inguinal ligament, giving you that triangle, and you can feel a pulse there. The other reason that's important is if someone gets in a major car accident or loses their lower portion of the leg, you can put pressure on the femoral artery here to keep them from bleeding out. And the femoral artery branches. You actually have a deep femoral artery, which is going to obviously go deep, and just the femoral artery, which is going to come across and go back. So we can actually see the femoral artery, the deep femoral artery here, and you can see how it has a branch that goes around the femoral neck here. The arteries that feed the femoral neck, most of them are coming from the deep femoral arteries. And if there is a fracture of the femoral neck, a lot of times these tributaries that feed the femoral head die. And that's why a lot of times when someone gets a hip fracture, they have to have a hip replacement because of the avascular necrosis. Now, there are some activities that seem to lead to damage to these arteries to the femoral head, and that would actually lead to avascular necrosis, but there's not much research done on that. Now, you'll notice that the femoral artery goes to the back of the knee, the area called the popliteal fossa, and so the artery there is now called the popliteal artery, and you can put pressure there and push down on the popliteal artery. Again, if someone loses lower portions of the leg, it is a place you can keep the person from bleeding out. And what you see is you see a branch here. One of them goes to the front and is going to be the anterior tibial artery. It's going to follow the tibia. The other one is called in this one it's called tibioperoneal, which is a fine name, but I actually would tell you to use, if you're in my class in particular, tibiofibular, because it tells you the bones. Tibio for tibial, fibular for fibia. And so you have the tibiofibular trunk, which is going to branch into the fibular artery, and the posterior tibial. And so this is going to be in the back of the tibia and following the fibula, mainly the posterior portion of it. Now, one of the things is with these arteries, again, you can have some variation, and what you're going to have is you also are going to have the fibular artery wrap around a little, and it's going to go to the top of the foot, giving you an important artery called pedis dorsalis, or dorsalis pedis. And the reason that one's important is because that's one of the last places you can feel a pulse. Besides being able to cut off the blood supply if you need to, which at that point it's not really going to be that big of a deal. They're going to lose a foot, so that's a big of a deal. But the reason that artery is a big deal is if you lose the blood supply there, it does cause the foot to lose blood supply. And usually people with diabetes will end up having atherosclerosis, which cuts off blood supply at the farthest points of the body, And so in this case, the foot being the farthest is where you would see it. And if you lose the sensation, the pulse in pedis dorsalis, or dorsalis pelvis, as it says, what you would end up having is you would end up having loss of blood supply to the foot, and so your diabetic patient will start losing toes. That's why some people say diabetics should have their dorsalis pedis checked every medical visit. Now, there are some stuff I actually think is very important for you to know. One of them is what is the border of the popliteal artery, and there's the same borders that are making up the popliteal fossa, so semimembranosus, biceps femoris, and the gastrocnemius. Pedis dorsalis, it actually goes lateral, it's actually lateral to the extensor hallucis, comes around, and it pretty much is important for diabetes, like I said, because due to diabetic atherosclerotic conditions, they can end up losing sensation they can actually lose circulation of the toes and end up losing toes, and as they lose sensation, toes can end up getting injured and fall off. Now, I talked a lot about fetal circulation, and that you do have some shunts for blood because you don't need it going to the lungs as you're in amniotic fluid and you're breathing that in. Within the heart, we actually talked about how there's the ductus arteriosus between the aorta and the pulmonary artery. And we talked about how between the atriums, there is a foramen ovale which closes up and becomes the fossa ovalis. Between the umbilical veins, which is a vein that's actually bringing blood back to the body, and the inferior vena cava, you have a duct bypassing the liver, and that is actually going to be the ductus venosum. Now, the ductus venosum is going to close off, and what you're going to end up getting is the ligamentum venosum. It is actually found in the liver. And that's actually one of the big things. Where the umbilical arteries are going to come, and I don't have a good picture of this, are the internal iliac arteries. They go to the placenta, and they are two umbilical arteries. Remember, they're going away. Veins bring it back. And one of the things is all the shunts that I mentioned, up here, the shunts, the ductus arteriosus closes, becoming the ligamentum arteriosum. The foramen ovalis closes, becoming the fossa ovalis. The ductus venosum closes, giving you the ligamentum venosum. And so that's actually the end of this lecture. I hope you enjoyed it. I hope you found something useful and it helps you understand a bit more of anatomy. If you have any questions, please write them down in your comments. Thank you and have a nice day.